Today we are discussing about trauma series 11, geriatric trauma. In geriatric trauma, we are going to discuss airway, breathing, circulation, disability, exposure, and environmental control, and some special circumstances also. First, we are discussing about some physiological changes in the airway in geriatrics are the arthritic changes in the mouth and cervical spine, and macroglossia, decreased protective reflexes of airway, and definitely it is going to be a difficult airway. So we have to use appropriate laryngoscope size, blades, and tubes. In case of edentulous patients, we have to place a gauze between the gum and the cheeks to prevent the leakage of the gas when bag and mask ventilation. About the intubation medications, we have to consider the cardiovascular depression with the drugs which is used for intubation. Therefore, we have to reduce the dose of the intubation medication by 20 to 40 percentage. Benzodiazepines, barbiturates, and other sedatives we have to reduce. Second, about the breathing, increased kyphoscoliosis, which will cause reduction in the transverse thoracic diameter, and functional residual capacity will be reduced, cough reflex will be reduced, and there will be more chance of aspiration. Decrease in the mucociliary action also will cause more chance of aspiration. So lung recoil will be reduced, chest wall recoil will be reduced, and there will be limited reserve. So early respiratory failure is possible in case of elderly. And in breathing, there is suppressed heart rate response to hypoxia. So tachycardia should be carefully evaluated. So rib fractures will cause more pneumonia. In 30% it will cause pneumonia. And about the management of rib fractures, pain control and pulmonary hygiene are important. To limit the use of narcotics to avoid the prolonged delirium which will happen in old age. So regarding intubation, so frequently the decisions to secure a patient's airway and provide mechanical ventilation may be made before fully appreciating the underlying premorbid conditions like COPD. So we have to be careful while intubating such patients, and they are very prone for respiratory failure also. So during the intubation there is high chance of respiratory failure and cardiac arrest. Talking about circulation in elderly patients with trauma, it is critical to identify the patients with significant tissue hypoperfusion because the age related changes in the cardiovascular system may mislead us from identifying a patient who is hemodynamically unstable, and we'll count the patient as hemodynamically stable. The elderly trauma with evidence of circulatory failure should be assumed to be bleeding. Consider the early use of advanced monitoring, central venous pressure, echocardiography, ultrasonography to guide the optimal resuscitation, given the potential of pre existing cardiovascular disease. Regarding concerns in circulation, so most of the patients will have pre existing cardiac conditions like CAD, for which they will be taking medications like aspirin, clopidogrel. So, those patients will be very prone for bleeding. The beta blockers which they take will mask the tachycardia response. So, lack of classic response to the hypovolemia will be there. The BP less than 110 in more than 65 years will consider as hypotension in case of old age. So, less response to hypovolemia will be there, and therefore we cannot depend on the BP alone for a shock. So, we have to look for the general signs of shock, such as base deficit, serum lactate level, we have to see peripheral circulation, shock index, etc. So, regarding the disability, regarding the traumatic brain injury, the dura mater will be more adherent to the skull, and there is more chance of epidural hematoma if there is a trivial fall, even a trivial fall happens. And consider anticoagulant and antiplatelet reversal, even though the PTINR or APTT is normal. Regarding the spine injuries, the degenerative changes, the osteophyte can be there, which can lead to more chance of injury to the spinal cord. And common etiology of traumatic brain injury is falls. Falls means even trivial fall with the physiological and physical factors such as dementia, visual impairment, cognitive impairment will increase the chance of falls in case of older age group. And environmental factors such as poor lighting or a loose rugs or a slippery surface will increase the chance of falls. And traumatic brain injury, the signs of traumatic brain injury can be present even in delirium, dementia, depression, and all. So, liberal use of CT brain to rule out the traumatic brain injury. They limit the narcotic use in case of traumatic brain injury to prevent long lasting delirium, which is common in older age groups. Use smaller doses of narcotics or short acting ones, and use other means of anesthesia, like a local anesthesia or blocks whenever possible. And exposure or environment. In this, we can see that there is loss of subcutaneous fat in case of older age group. There will be more chance of pressure sores. Perform early evaluation and removal of the spine board and cervical collars will be useful. Pad the bony prominences when and where required to prevent the pressure sores. And more chance of hypothermia is there as the loss of subcutaneous tissue fat is there. So prevent the hypothermia by using warming techniques. This pelvic fracture can be possible even with trivial ground level falls, and more than 60-year-old will have osteoporosis and have more chance of fractures. There is actually 4 times more mortality than a young patient in case of pelvic fractures. So even stable pelvic fractures might require blood transfusions to get stabilized. Regarding elderly maltreatment, elderly maltreatment can be 6 types, can be physical, sexual, neglect, psychological maltreatment, financial, and violation of rights. Physical maltreatment can be because of hitting or pushing. Neglect can be because of abandoning and avoiding care. Psychological maltreatment can we can identify by depression, anxiety, or changes in behavior in the patients. And financial and material exploitation, changes in banking, changes in spending pattern will be giving a clue regarding that. So there can be subtle signs which can be missed if we don't examine properly. So immediately report to the authorities for further action. Actions to be taken along with the treatment itself. Conflicting history of illness and intentional delay in the treatment will always give a clue. 1 in 10 patients have in old age has a problem elderly maltreatment, but 1 in 5 only are getting reported. Now, how to find or when to suspect an elderly maltreatment? Basically, when unusual site of injuries occurs, like oral cavity, like in the palms and soles, like in the inner aspect of the arm, due to defensive positioning, and in the hidden areas like in the axilla, in the ears, in the mastoid processes, and unusual and pattern abrasions due to restrainment in ankles and wrists. With the specs on, if you're hitting on the face, it can cause ecchymosis around the eye and nasal bridge fractures, especially the specs can cause that. An unusual pattern of hair loss because of the pulling of the hair and fractures, especially the hip fractures, humerus fractures, the vertebral fractures, and hot liquid injury like scalding injuries in the scalp or face, and scalp hemorrhages, hematomas. Basically, when history or mechanism of injury cannot explain the pattern of injuries, then we should suspect a elderly physical abuse or maltreatment. Last but one word, in geriatric trauma, the injury severity and the host factor both contribute equally in mortality of the patient after trauma, and increased mortality for the same severity of injury as compared to a younger generation. So we have to be careful in dealing with the older generation people. And senescence to the organ is important factor to consider in elderly trauma.